55.
Okay, hello everybody. I'm Kurt Barnhart. I am the editor-in-chief for Fertility and Sterility, and I'm very proud to live stream our Journal Club Global series and seminar. We've had the luxury of broadcasting this seminar from many lovely countries, but never, I think, as lovely as where we are right now. I'm sitting as part of the 28th annual conference of the Indian Society for Assisted Reproduction, and it's a lovely location, and the hospitality is wonderful. So Journal Club Globals are live streamed, so we'll be able to field questions from the audience online, but I hope we'll also field questions from the audience here in this auditorium, and I will facilitate a discussion with my panel here. At the moment, I have Dr. Madhuri Patel, I have Dr. Louise Hull, and I have Dr. Sujata Kar, and I think there might be more joining me shortly. I'm going to set the stage for what I hope is a lively discussion on a very, very important topic, which is recurrent implantation failure. I was happy to be part of a consensus conference about a year ago that was in Lugano, where we got at least 27 experts together to talk about what this etiology is, what it means, how do we diagnose it, and most importantly, how to treat it. I'm going to just present a few slides just so we bring everybody up to speed on what we're talking about, and then hopefully we'll have a lively discussion on how we see it in our own practice, how we manage it, and where we should go in the future. So can I get someone just to advance the slides for me? Wonderful. So I just have a few slides. I'll just state when yeah. So this is the paper from Fertility and Sterility which we're discussing, which is usually the hallmark of our Journal Club Globals. And this paper is entitled Recurrent Implantation Failure, a Reality or a Statistical Mirage. And as I mentioned, it's a consensus statement from a conference on July 1st in 2002 that we entitled Lugano Workshop on Recurrent Implantation Failure. I've heard the term recurrent implantation failure, or RIF, mentioned quite a bit already in this meeting, and I'm sure we'll already, but I'm not sure we actually even know how to handle this as a diagnosis. So next slide, please. So let's see if I can set the stage. Recurrent implantation failure is a diagnosis that we imprecisely give to patients that have more failure than we would like. And I think what happens is it started from the idea that as IVF has become more successful, each time a patient fails IVF, we start looking for an explanation. We sometimes forget that even in the perfect patient, a young woman with plenty of embryos with unexplained infertility, the ceiling of IVF success rate is really 50, 60%. So that's a lot of people that are failing despite everything going absolutely according to plan. However, it's frustrating for us as a clinician, and it's very frustrating for the patients. So when somebody fails a first time, we might say, that's okay, we'll try again. But when they start failing a second or a third or multiple times, they start looking for a reason, and therefore they start looking for a diagnosis. So that's where I'm going to start. I hear RIF in lectures and in papers across fertility and sterility often as I studied this group of patients with recurrent implantation failure, or this group, and I've started this intervention, but I don't even think we know exactly how we diagnose somebody that has recurrent implantation failure. And as you can tell from the title of this paper, there's a large group of people that think that the diagnosis actually doesn't exist. So we'll talk about that a little bit. This is some evidence in the paper that describes mathematically why there's a very strong feeling that recurrent implantation failure doesn't exist. You can see on this slide that if we had an imaginary 100 patients, the blue is those that are successful, the green are those that would be unsuccessful, and the dark green would be the hypothesized group of people that have this identity where they have a recurrent implantation failure. So at the first time, the success rate for IVF, let's just call it 50%. If you do it a second time, the population should be enriched with those people that have recurrent implantation failure. So again, if 50% of people get pregnant alone, you should see, in the second embryo transfer, you should see a success rate that's much lower than 50%. And if you do it a third time, you can see that the green group is now has a very substantial portion that can, quote unquote, never get pregnant. So your success rate in the third embryo transfer should even be lower. So if it really existed, we would concentrate the people each time we did a transfer. And what people have suggested is that's simply not the case, that we actually get relatively stable pregnancy rates with a successive embryo transfer, begging the question, is there a group of people where this is a problem? So these are cumulative graphs that we drew to say, if we thought that the recurrent implantation failure was 10%, you would be, at 1%, you would be at the gray line, the top line, which is going down. That with each embryo transfer, you should have a lower successive pregnancy rate. If the success rate was 2%, it should be approximately at the orange line, and if it were 5%, it should be the blue line. The red line is the actual data that we have when you have a euploid embryo transfer. This is Paul Pietro's data, along with Richard Scott, where with diagnosed normal euploid embryos, that graphs the success rate of implantation or successive implantation. And the red line is showing that there really is not a large decrease in the second or the third transfer. So by that argument, it's really just math, that there's a small group of people each time that don't get pregnant, and this condition really doesn't exist. You could continue transferring good quality euploid embryos, and eventually 90–95% of people would become pregnant. Of course, that I just opened the door for the issue about which is more important, the embryo or the uterus. I talked about the ploidy status of the embryo. If the embryo does not have normal chromosomes, most of the time is not going to result in a pregnancy. So therefore, when you're evaluating someone with repetitive IVF failures, age is going to be a very, very important topic. And this graph is showing us that what the chances are of having normal euploid embryos based on age. What I'm saying is, at a young woman, you can make an assumption the embryo is chromosomally normal, but when you get into the late 30s and early 40s, you can't assume that the embryo is normal. So therefore, you can't assume it was a recurrent implantation failure because you put in not necessarily a normal embryo. Again, arguing that this might be an embryo issue rather than an implantation issue. If we were to use that magic number as proposed by many, that if you have 3 normal euploid embryos, 95% of women will get pregnant with up to 3 transfers. Not everybody uses pre-implantation genetic testing. Therefore, we have to extrapolate to how many embryos that would be based on your age. If you're a young woman, the top line says you would need to transfer 4 good quality embryos before you would make an assumption that you're beyond that 95%. If you're 35 to 37, it would be 5. But that number escalates very quickly. When you're 38 years old, you need 7 normal embryos. If you're 41 to 42, you need 13. And in the rare case, if you're doing IVF in someone greater than 43, you have to transfer 27 embryos before you say the issue was not simply the likelihood that the embryo you transferred was not chromosomally normal. So with that as an introduction, let's talk about, does the diagnosis of recurrent implantation failure actually exist? Some possible reasons that people have talked about, and we'll have a discussion here, are can you call somebody to have reproductive implantation failure if you've only done 1 IVF cycle, if you're dealing with only 1 cohort of embryos? Where does the role of uterine factors play in this role? What's the role of endometrial receptivity, endometrial thickness? And I've been to a wonderful presentation today about the microbiome, about generic inflammation, progesterone, and even male factors. So I'll leave it as the introduction. I have posed what I hope is a very provocative question. I've heard the term RIF more than 20 times already, and I'm suggesting that perhaps that diagnosis isn't even made correctly or doesn't exist. But if it does exist, what do we do about it? Which of these tests should we be getting, and what therapy should we use? So let me just go around the panel, and now that I've given that introduction, and say, do you use the term RIF to your patients, and if so, how do you make the diagnosis?
So yeah, I do see my fair share of RIF, not very commonly, as would be expected. Maybe once in a month, once in 2 months, I have to sit down with a couple and say that, okay, you fall in the category of RIF. Now, most of the time, the problem is to actually pinpoint the diagnosis. If one bases on the typical definition of RIF, which means good quality embryo or a euploid embryo, a normal uterus, a normal endometrial thickness, those are the definitions for RIF. Most of the time you have something in the back of your mind, no, the age is more or the BMI is more, or maybe the uterus is not near perfect because we only look at the cavity and we say it's fine. But what if there are some intramural myomas or she has some adenomas? So what I'm saying is that it's very difficult to pinpoint a diagnosis of RIF in most of my patients. So what I generally do is when they have a 3-time failure of good quality embryos, and to the best of my capability, whatever workup I have done before IVF, and those appear to be okay, nothing more that I can do about it, I categorize them as RIF. And I have a series of printout which talks about all the possible tests that one can do in cases of RIF. And I sit down with them and counsel, okay, this one, this one, this one, this is so costly, this is like this like that, and then take it forward from there.
Excellent. Do you use the same diagnosis of RIF, 3 good quality embryos, or do you have a different diagnosis?
I mainly see people that have had a lot of IVF before they've seen me. I don't find it a particularly helpful diagnosis at all, because I think the people I see are at the point where they've done so much IVF already that they need more answers than just, well, you've had more than 3, this is what we do, and a protocolized pattern. So I think somewhere along the line you've got to at least try and get high quality embryos and euploid embryos and see if that might be what's going on, or explain on the basis of age that that might be what's going on. But then I do think there are endometrial factors that people don't diagnose at all well, and endometriosis would be the most classic example. We give a diagnosis of unexplained infertility and then recurrent implantation failure, which is 3 embryos haven't taken, and that's not a diagnosis. That's a number, you know, and where we haven't actually given them the answer to what's wrong. And I think one of the big issues is we've been terribly underfunded in women's health to get good diagnostics in endometrial disorders. And I think we really don't have good diagnostics, and microbiome is an example of a new test that's still not validated. We validate terribly badly in RIF, because 70% is already the embryos, and when you look at like the ERA tests, they've all been done in first IVF cycles. They have not been actually done in recurrent implantation failure. So we don't actually know about that tiny little group that they might be beneficial for, because we can't find that group because we've got bad diagnostics. So I think once we get better at diagnoses, we can actually start targeting proper treatments to the right thing. But in the meantime, we use add-ons and generic empirical treatments because we don't diagnose properly. And so rather than focusing on RAF and how you treat that, you need to find out what each person's RAF is and target the treatment to them, not to 3.
Dr. Shah, what's your initial thought?
Yeah, so basically, I think all these patients who come to us for IVF are heterogeneous because the cause for their infertility is different, and each of them have their own personal features also, like their ovarian reserve. And especially in India, I mean, we don't do a PGTA for all our patients because IVF is not covered under insurance and the patients need to pay. So we have all classes of patients over here. So I think we really do not do PGTA for all the patients. And so we do fresh embryo transfers. So we don't always do frozen embryo transfers. So I think in my practice, if a patient has failure more than 3 times, where I include both the fresh as well as the frozen embryo transfers, probably then we need to say that probably she has RIF. Initially, before the patient undergoes ART, we basically do all the basic investigations which are required. I don't think we do the advanced testing. But once the patient has repeated failures, and probably during our stimulation we find there's some cause, or when we do the oocyte aspiration, at times we find that the egg quality may not be good, or the embryogenesis not good. And all this, when we talk about this to the patient, it's very important to see that the conditions in the lab are the best, and even the clinician has stimulated the patient optimally to say that probably that could, we have to rule out that as being a cause. Because in India we have many, because it's a highly populated country, we have now IVF centers coming up in small towns and cities, and most of them are private. We don't have many public IVF centers in India at all. Now there are a few corporate where they have chains of IVF centers, but in public hospitals we still do not have any IVF centers. So all the patients pay for their own treatment, and basically the investigations also what we do for the patient will depend upon where the patient is going to take treatment. So if you go to a smaller town, they might not have all the facilities. They might be providing an IVF service, but they may not be all that competent, and because they have few number of embryologists, they have visiting embryologists, so the quality control in the lab may not be maintained. So I think in Indian scenario, we also need to look at these factors. And as in this paper, I mean, it was transferring euploid embryos, and then you had a pregnancy rate of 95% in 3 cumulative cycles. And it was just 5% which was, I mean, who had recurrent implantation failure. But I think that same cannot apply to the Indian population.
So those were all very good explanations. And I'm going back to this slide on purpose. So what this paper discussed was that not that you should be doing pre-implantation genetic testing on all embryos. What it was basically saying was that if we look at embryos that were tested, and therefore we, for best of our ability, can say that that's a normal embryo, people don't have recurrent implantation failure until at least 3 normal embryos are transferred. Now, I've heard all of you say 3 normal embryos, but we don't know they're normal, right, unless we do pre-implantation genetic testing. Please come join us. Sorry. That's okay. So I just want to remind everybody that we just colloquially use the definition 3 amongst ourselves, but really, based on the patient's age and looking at this data, it should be probably more. It should be, in someone over 35 years old, it should be at least 5 good quality embryos. In someone that's 38 to 40, it should be 7 good quality embryos before we call them recurrent implantation failure. So
one other factor I would like to discuss, that it's also been seen that the ovarian reserve basically is, I mean, the Indian patients age much before the Caucasian population. So the same patient, if you take a European or a patient from US, and if you take an Indian patient, the ovarian reserve is much less at that particular age. And the other factor what we need to take into consideration is also the endometrial factor in India, especially where we still have tuberculosis, and many patients come to us with chronic endometritis, and that is one of the causes of implantation failure.
Right, okay. Thank you for joining us. Why don't you give us your thoughts briefly on how often you see recurrent implantation failure in your practice, and how do you define it?
Thank you very much. Sorry, I got a little delayed. But you know, recurrent implantation failure is a term which we use very loosely, actually, because maybe I'm a tertiary care unit, so I see a lot of patients who have failed in other units and come to us. So then, you know, okay, this is a patient of recurrent implantation failure, because they've had multiple attempts of IVF. Now, what we really, today, what the discussion is very, very relevant. You know, especially in a country, large country like ours, there are many centers. We don't know the success rates of each center. So you don't know what has been the quality, what is the implantation rate of that particular lab. So I think we need to define it a little differently. You've done aneuploidy, but we don't do PGTA in all our patients at all. So yes, the number of embryos, the quality of the embryos is really important, but also you know, I believe that the lab also plays a very important role, because if your lab consistently has a 30% pregnancy rate, I mean, that's a standardized lab. So I think that also has to be taken into account, especially if we want to apply it across the board. So maybe not 3, 4, it depends on how many. So in our practice, yes, when patients, and it's also the psychology of the patient, Kurt. Because when a patient comes to me with 2 IVF failures, they want to know why, and they're devastated. And remember one thing, in India, they are paying money out of their pockets. So for them, they want to do all the tests, they want answers, they want results. So maybe we are forced to doing a lot of tests, a lot of results because of that.
So I heard some very important points, and I'm going to put you all collectively, not individually, on the spot here. So we are using the term recurrent implantation failure, yet I've heard many of the reasons for implantation failure might be
cycles myself with the patient, then maybe I can point a diagnosis of RIF. But if I'm doing a 3rd cycle or a 4th cycle where she's done somewhere else, so that may not be easy to pinpoint a diagnosis of recurrent implantation failure. That's what I think we were trying to say.
Yeah, no, I'm agreeing, definitely agreeing with you. What do you think of that? Are we using the wrong term? Is this just a basket term for patients that have...
Probably we should use recurrent IVF failure rather than implantation failure, because if we've done the cycle, probably we know we are looking at the endometrium, we are looking at the embryo, we're looking at everything. But if the patient has come to us where she's done her cycles earlier, as Sujata said, we really cannot point out that it's implantation failure. And the other thing also, what we need to take into consideration is the technique of embryo transfer, and that is individualized and it's personalized, because it depends upon the training of the clinician and how many cycles they would have done. So we also need to look at that perspective.
I think what you're trying to say is what's the cause of the embryo not taking, and when we talk about recurrent implantation failure, often we're talking about an endometrial cause, but I think a lot of it is embryo. I think there's some that's lab, I think there's some that's transfer, there's a lot that's male factor, and then once you've looked at all of that, there are endometrial factors that Asherman's, endometritis, antiphospholipid syndrome, and probably to some extent a bit of endo or adeno. There are endometrial factors, and I think they're real, and we don't measure them well, and we don't diagnose them well, and we've got to understand that they're there, but putting the RAF at 3 before you think of endometrial factors isn't that helpful. I think it's better to say, look, we're here, the patient's 43, the endometrium was great, we've checked all their metabolism's fine, it's a euploid embryo, we're going to need 27, or we can't test an embryo. It's much more likely to be an embryo factor. How do we change that? Do we do donor, or do we screen, or what do we do? Whereas if you've got someone who's 28 and you've got lovely embryos and they're euploid, and you've looked at the metabolism and you've done all the other side of it and the lab's working, you've got to think, well, maybe there is an endometrial factor. And then that's where you do have to do a hysteroscopy, or you do have to think of screening, even though we've got bad tests for it. Do they have some adeno? Do they have some endo? Do they have endometritis? And I think you've got to take that into account. Mm-hmm. Is this likely to be endometrial, or is it going to be something to do with the embryo, which also includes the male partner?
So I think we just had a breakthrough, which is we are all nodding at each other in agreement. And I think the agreement is that we are probably using the term RIF incorrectly. So I think most people, when they hear RIF, think there must be something wrong with the implantation or the endometrium in an otherwise normal embryo. We all disagreed. We said this is not recurrent implantation failure, meaning there's a problem with the actual mechanics of implantation. We are saying it's recurrent IVF failure. And recurrent IVF failure may have multiple causes, and that's what I'm suggesting in the slide here which is we need to really figure out what it is before we call it RIF. If we think they came from a suboptimal program, perhaps it's the laboratory conditions. If we think that they had a very stenotic cervix, perhaps it's the difficulty of the embryo transfer. If we think that they have underlying disorders like ASRM syndrome, that's not unexplained, that's a problem. Right? So I think what I'm advocating, and we're all agreeing, is let's use the term a little bit more precisely. We all understand there's patients that are not getting pregnant, but perhaps the diagnosis term we're using is incorrect. Why do you think we've adopted an incorrect term in our field? Is it just easier to tell the patient you have RIF and therefore they accept it and we feel better? Why do we use the term incorrectly?
I think most of the time, because we usually, when we are doing an embryo transfer, usually if you see good quality embryos or euploid embryos, you end up telling the patient that your embryos are very beautiful, they're all good, number one. And number two, usually when we put them into the program and we test them, we tell, yeah, things are fine with you, you can undergo IVF cycle. And when she fails 2, 3 times, 4 times, then you are forced to call it a recurrent implantation failure, because you've told her it's a good quality embryo, you told her her investigations and everything looks fine. That would be my thought.
Yeah.
You know, Kurt, I think implantation is a crosstalk between the embryo and the endometrium. So I actually think implantation involves the embryo, the endometrium, and the woman. I mean, her metabolism also. So I think I beg to differ that it may not be an incorrect term. I mean, it would probably, the causes are all of them. So yes, by doing the aneuploidy screening, you're taking out the embryo part of it, where you're focusing on it. But if you look at the whole picture of implantation, it involves all the factors, doesn't it? I mean, the embryo has to be normal, the endometrium has to be normal, her whole body metabolism has to be normal. So in a way, I think the whole thing implies that it's the holistic approach for the woman. I mean, that's my take.
That's a very good take. You want to comment on that? Or?
Yeah, I also feel, I totally agree with Nandita that it's both the embryo as well as the endometrium which is important, and it requires a dialogue between the two for the implantation to happen. So there could be several other factors apart from the anatomical factors, like there could be abnormalities in the immune system, in the receptor expression, there could be different changes in the cytokines, and all these are especially seen in patients who have adenomyosis as well as endometriosis. So the implantation process does not only involve the embryo, but it also involves the endometrium. So I think we need to take into consideration both these factors, and which are not identifiable anatomically. Like if you have a polyp, if you have a fibroid, I mean probably you have intrauterine adhesions, we can identify if there's a uterine factor. And I think we also need to look at the thickness, because normally we say the thickness of more than 7 millimeters should be there for a proper implantation to happen. So I think many a times, even with good amount of estrogen, when you're stimulating the patient, we have patients with thin endometrium. Many a times when we're doing an HRT cycle, we have a thin endometrium. So probably then we need to go further and investigate why the patient has got thin endometrium. I mean, before treating her, because we should actually know the cause, what is that.
Yeah, because you've just ruled out that 95% of RIF is due to embryo. That's what I feel.
Okay. Yeah, well, there's an argument with the scientists in this field, and we need more research in it, is that if you said everything went well in an IVF cycle, it was optimized as best you could be, you can't identify there was a problem with the media or the retrieval or the transfer, and a very normal embryo with normal chromosomes does not result in a pregnancy, was it the fault of the endometrium, or was it the fault of the embryo? We don't know. I mean, we have people that argue on both sides, and I think my personal opinion is because we had started to develop tests of the endometrium that we focused on the endometrium, but I'm not convinced that's the sole reason.
I don't necessarily think it's the sole reason, but I think we are so bad at investigating the endometrium, and it's the last frontier for us, really. Mm-hmm. It's the big black box. We don't know how it works, and we're not very good at testing for it, and none of our tests of it are very good. And we test in a population where 70% of the time the implantation failure is related to the embryo. So we just haven't got the power to work on the rest of that group. Mm-hmm. And some of them, if you're using, for example, an immunosuppressant, even in the group that had normal embryos, there's only going to be a small number that actually have antiphospholipid syndrome, and we're testing all the guys with endo and Asherman's and endometritis and any other cause of endometrial disorder. And we're not actually using our drugs and our tests in the subgroups we need to, because we can't actually identify them very well. And that's a funding issue. It's a, now we can actually genetically test and work out the embryos. We now can look at the lining of the womb in a different way. And that's why we are getting a lot of new tests. Right. But we need to work out how to use them. We need to work out which population to use them in. And we need to work out the drugs that work in that population. And at the moment, we're just throwing things at people, which is not the way it's going to work. Because if you have an infection and you give someone prednisolone, it's just going to make it worse. So, we're not doing it cleverly. And it's all about testing first.
That's a great segue. I want to go back to the point that, again, we were talking about aneuploidy and euploidy of the embryo as a way of focusing in on something else. We're not advocating that all embryos need to be tested. But if we are going to focus on the endometrium for a second, let's talk about the tests that we have. Really, we have, in my opinion, and I'm doing this provocative on purpose, we have two tests. We have ultrasound, where we can look at the thickness and the pattern, and we have a molecular test called ERA that we have a seminar on later. So how do you evaluate the endometrium when you have a patient that has recurrent failure like this?
Can I argue about the number of tests you have there?
Of course, please.
I think you've got lots of tests. So you've actually got hysteroscopy, so you can check for polyps and Asherman's and things like that.
Sure.
I think you've got very, very good endometriosis scanning coming along. Mm-hmm. So a lot of the time you can actually diagnose that non-invasively now, and that gives you a lot of answers, and especially adeno, which may have an impact. And again, we don't do it well enough to know how much of an impact it has, but we're learning. And I think there's a pre-publication actually just saying if you diagnose with an ultrasound severe endo, the IVF outcomes are worse. And that's the first time we've had a non-surgical ability to do that, a non-treated population. But then I think the microbiome test, it's in its infancy. We don't know how well it works, but we've not used it very much. And it may be very useful for some people. I think ERA, we've tested in the wrong populations. And I think also the metabolic tests, we really don't look at pre-diabetes. We don't look at some of the real metabolic things that we could probably give people a tablet for, or vitamin D, or, there's a lot of things we can do for women and men that would help implantation. And we certainly don't do it in men very often. And I think we need to be doing all of those things. But once we could do those tests cheaply and well, and we've had enough time with them, I think it'll get easier.
I agree. That's what we're going to end with, is an eye to the future of what we're testing. But before we get there, let's go around the table. What else do you do to evaluate if we've now decided we want to focus on the endometrium? I mean, I agree, we should be looking at anatomical causes before we did IVF. We should know whether they have adenomyosis. We should know whether they have fibroids. We should know whether they have adhesions before. So they shouldn't technically be in our recurrent implantation failure because that's the cause. Assuming that's normal, what do you do for your patients?
I usually do not do ERA and other receptivity factor tests in my practice. I don't have the facility to do it. So I mostly depend on a normal transvaginal ultrasound report, if that's okay, and if otherwise anything is there in transvaginal, might do a hysteroscopy, might do an endometrial biopsy. Other than that, I don't do. Sometimes I might do a blood flow study, the power Doppler or 3D power Doppler studies to look at the blood flow if that is optimal. But that again, for very few patients.
Okay, Kurt, I practice in a metro city. So what we do, besides what you've talked about, both the girls have talked about, what we are doing is a microbiome. We are adding it to our protocol now. So we have a comprehensive microbiome, which not only tests the lactobacillus, but also tuberculosis and the BCL9. So BCL6, sorry. So even endometriosis, sometimes, the patient doesn't want a laparoscopy, because they've gone in for multiple IVF cycles. So we do the tuberculosis and the endometriosis BCL6 along with the lactobacillus. So that is one additional test. And there's another thing which I've started doing is precision medicine. So we do have precision medicine where we are studying the genetics we collect the blood and we send it to this lab, which has a particular panel which actually tells me about the implantation genes. So it's not evidence-based, it's still coming into it, but it's been there around for 10 years now, okay? And there are lots of articles, and you know, I've read your presentation. Yours is based on, there's no meta-analysis, right, in it, right? So there are studies which are coming out, and believe me, I have experience with a few patients. I'm not saying I've got too many patients with it, but some of the genes come of the thrombophilia genes positive and all. And obviously, initially it was, oh, I'm not doing evidence-based, so I would be worried. So when I have a failure in those patients where these genes have come positive, the thrombophilia, we advise anticoagulant, and I haven't given it, then in the second or third attempt, I give it, I've had good results. So these are a few cases. I cannot. But I feel that precision medicine is going to change our scenario. It is, the evidence is not there. It's slowly coming in. But a lot of things, as today's lecture on the ART Act, he said even when Louisa Brown was born, there was a lot of debate that this IVF technology is not going to work. And look where we are today. So I think it's changing. So I add these two things. And also another thing which I'm doing very controversial right now, because I get failures of 7 failures, 8 failures, 9 failures, is we do immunological tests. And a few patients have had lead therapy. I've had patients coming from America, the doctors have said, go to India, take lead therapy. So that is another thing which we are doing in a few patients. So I believe, Kurt, that there are small pockets of patients, okay, who need it. I'm not saying everybody needs it. Very few, maybe your point whatever % patients, you do the test and you find that the immunity is lower, because you have tests for kidney transplantation, those will reject. So those are the tests which they are applying in this, and their rejection is negative. You know, so these are the extra things which I do in some patients.
See if there's a counterpoint to that, or you do the same thing?
So basically, I normally do a 3D scan before we submit. We don't do hysteroscopy in all patients, but if you have, unless there is a finding on my 3D or a 2D scan where I would like to do a hysteroscopy before I go for IVF. But if I've not done earlier and I would definitely do hysteroscopy, and I would probably do a hysteroscopy directed biopsy in case it is indicated. And especially, as I told you, in India, the chronic endometritis is quite a bit. So we send this tissue basically for CD138 as well as for tuberculosis. And if that's there, we just treat these patients. I have tried ERA, but I didn't find it to be useful, so I've just stopped using it. I've done it in about 50, 60 patients, but I found that it didn't work well for those patients, so I don't use it. I've hardly done those other tests which they do for chronic endometritis and for microbiome. And at times I feel, especially those patients, when I evaluate the thyroid and I find that they do have an antibody which is positive, because that is also one of the causes wherein there could be a recurrent implantation failure because of the immune causes. So in that, I basically look at the ANA and the alpha-glycoprotein 1, basically, which are more associated with implantation failure. I don't normally routinely do the protein S and C unless the patient has history of thrombophilia, and I would not like to do. So I would basically do these tests, and then depending on that, I would counsel the patient, because initially before the patient goes for an IVF, I would tell her all the reasons, and where we could tell her that we can give you guarantee till the formation of the embryo and tell you about the embryo quality. But once we put it inside, whether the endometrium is going to accept it or not is not known, and therefore we don't have a 100% success rate. So this is what I normally tell my patients.
even the platelet infusion that you're talking about, that is also something which we do. In fact, in India, there is a company which is now offering artificial intelligence with, putting in patients' data, their history into it, and they give 3 samples. One is in the follicular phase, one is at ovulation. So 3 samples are put in of the platelets. What is told to us is that each part of the cycle requires a different set of growth factors. So that is how they give those samples. So I'm just telling you what is available and what is there.
We're at a segue here, and I want to get back to this in a second, but right. But given that we have about 15 minutes left, I want us to open up to the audience to see if anyone wants to challenge us or has a specific question before we start talking about the utility of some of these therapies. If anyone does, please come up to the microphone, but I'll continue as well. When I've thought about recurrent implantation failure, or even unexplained infertility, or recurrent pregnancy loss, the really frustrating clinical dilemmas in our field, I find that there's 2 camps. There's the numerator group and the denominator group. The denominator group is perhaps more like myself. Maybe that's why I'm an editor for a journal. You know, you really want evidence to show that it works. You want to demonstrate that it's going to have more benefit than harm, that it's cost effective, and you want to limit yourself to therapies that have worked. But then there's the numerator group that's more like the clinician that says, I want to help that patient right in front of me, and even if I don't have a test or a therapy that has been proven, what's the harm in trying? And I think we have a little bit of this even on our panel here. So I'm curious on what your thoughts are about that, and which one do you think you might be in?
I think that's a big problem, because I don't think the denominator that we use is actually people with an endometrial disorder. Mm-hmm. So I think that's a big problem with all treatments. We've used them in people who largely have an embryo disorder to try and evaluate endometrial testing and treatment. And so we're not looking at the right population at all. But all the evidence is that in that population, which is mainly embryo problems, it doesn't work. So nothing works, so what do you do? How do you move the progress forward if you're just saying, I need so many people in the denominator to see the difference that I'll put a whole lot of people that actually don't have the disorder in there?
So what you're describing is the lack of precision of understanding who we're trying to treat.
Yeah, so right. If you treat someone with endometritis with antibiotics, it's different than treating somebody with endometritis, Asherman's, embryo problems, and, you're not going to see the difference. Right. It's going to be mobbed by the huge number of people that didn't have the condition. And I don't know how you can design studies to improve that with enough power and enough precision to get the group that you're treating, given that, if you treat with autoimmune issues, a lot of the other things get worse. If you treat, but a lot of the treatments for one thing won't affect the others, and you're actually not making the diagnosis to get the group right, if that makes any sense.
There's clearly a consensus, again, that we think that there are probably other abnormalities in a woman that we have trouble getting to diagnose, and that the therapy is probably more personal or precise if we were able to understand that. I agree, that's a big research need, and that's where research should go. And my first call to everybody here and watching this Journal Club is the first step in doing that is to use the correct definition of recurrent implantation failure so we can actually study this. So I'm not sure we can come up with that consensus at the moment, but I would say please be precise in your definition, and there may be, again, subsets that you're talking about, not just a general group of people. But the question I want to end with is a more practical question for this clinical audience. Those are future therapies, but let me very briefly review where the evidence stands according to this paper. It does not suggest using the ERA testing because it has not been proven in a number of trials now, both cohorts and randomized trials, to actually improve in a population sense Whether it improves the individual in front of you is a question that's hard to answer. We also went through the fad of endometrial scratching. That was very popular, and some good randomized trials shows that also didn't have a benefit. Immunologic treatment has also had its ups and downs in literature. There are true components, but again, I don't see compelling evidence that is a viable therapy. And the platelet infusion has a wonderful logic to it, but again, I haven't seen any evidence to show that it works. Now, I'm not saying don't ever use these therapies. I'm saying we have to have the balance of, does the patient understand that it's experimental? Do you understand that you're trying to help this patient? And I hope you're taking into account potential harm and potential cost. Luckily, things like ERA and scratching haven't demonstrated harm. They've just demonstrated no efficacy. But some things that we do may have harm, and we need to pay attention to that as well. So let's go around the table and say, now that we've talked about this, how are we going to approach this patient that has a normal workup, that's just restricted to normal anatomy now, and has multiple IVF failures? So let's go around.
So basically, when we don't really know the cause, it's very difficult to treat the patient because we don't have anything specific to treat. So here I think we also need to counsel the patient about her lifestyle, which is very, very important, because we know that high BMI can also affect the implantation, whether she's a smoker, she has alcohol, or any other drug addiction. So this is an important factor which we need. And more so is the stress factor. And therefore, a psychological counseling is very important. The clinician also could do the counseling, but along with that, if you refer the patient to a counselor, it would really help. So in my practice, I basically don't use much of the add-ons, except if I have a patient who has got a thin endometrium, then probably I would do a PRP, or I would use the GCSF. Otherwise, that must be, I think, 1 or 2 cases in a whole year and not more than that. Otherwise, basically, it's just counseling. And what I feel is when I tell my patients to do some meditation and yoga, it de-stresses themselves, and many a times they come with a spontaneous conception itself.
Please.
So I would, and I see a lot of people with a lot of embryos. So first of all, you've got to get both a bit metabolically normal embryo, and then I would be at least trying to test, or if they have a miscarriage, try and test the products to find out about, if you can find out the chromosomes, you've got something, because you rule out a lot of things. If they're normal, I would be thinking of other things a bit more. I would look at the man and look at his metabolism, and often a sperm count won't tell you that he's pre-diabetic or sometimes even diabetic, or sometimes they've got a very high oxidative stress index or very high DNA damage or something like that, and we're actually looking at the wrong person. Then you've got to look through every stim that they've ever done and see if they actually triggered on time, and who did the transfers, and was it easy and things like that. And if it wasn't, you've got to do a hysteroscopy. If they haven't had one, you probably need to look in the uterus, or at least get a very good scan. We would normally do an endo scan, but some people need a laparoscopy. And then you start thinking of some of the trickier tests when you've not found anything. Do you look for endometritis? I've certainly had some people who clearly had a chronic endometritis that you would not have picked up on any of those tests, or with plasma cells. So I think, and then you start thinking of these things, but you have to counsel patients when you're getting into expensive stuff, but often they're bringing it to you. They're saying, I want this, and I want this. And you have to say what the evidence is behind that and what it's going to treat. And probably the thing that concerns me the most is I see people being offered anti-rejection drugs that will actually wipe out their immune system in the endometrium and affect implantation negatively. And I think you've got to try and at least explain some of that so they don't take up things that are probably not going to help them at all. If someone's got Asherman's, giving them, Internicet and 5 different anti-rejection drugs is not the treatment for Asherman's, or if someone's got an undiagnosed endometritis, it's the wrong treatment. So, you know, just being able to get some, you know, to be able to explain some of the harmful things. But a lot of things aren't harmful, and I don't get too worried about them. But the things that are, I would worry about.
Great, well said. Yeah.
Thank you. I think what Kurt is talking is normal tests, you know, the routine tests, hysteroscopy, everything is normal. Remember one thing, sometimes in a multiple IVF failure patients, laparoscopy is not done. So I think one thing that we can include in our armamentarium is do a hysterolaparoscopy. The second thing, that if I have a patient with everything normal, counseling is very important, talking to her, and what Madhuri has said about getting her, you know, lifestyle change. And obesity, I have this new drug, semaglutide. I use it to get the woman to lose weight before the IVF. That's something which I use. Yes, I do use it. And the other thing is, yes, I do offer them the microbiome test, the precision medicine test, and immunological. See, if my patient has had so many failures, I do it. And of course, it depends on whether the patient can afford it or not. And a lot of times we help them with the money also. You know, we can get some assistance from somewhere, which a lot of laboratories do it for us. They would subsidize the cost for the patients. So those who can afford it, do it. But there are a lot of laboratories. I think Dr. Durusha is sitting here. Metropolis does it free for me at times when I request them. You know, so we do have these options to offer to these poor people. So I do the whole thing. If there are patients who have had all these multiple failures. Before the law came, we used to offer very openly surrogacy, egg donation, because we had no answers. So yes, third-party reproduction was one of the options out for people who had everything normal. I'm being very practical, Kurt. I don't know. You know, I mean, there was, when you have no answer, you have to sometimes offer the patients something.
Okay, so after everything that Nandita, Dr. Louis, Madhuri, they have done, I don't have much options left for my patient. No, I think I will, in fact, I do counsel them about the value of repetitive IVFs. And what tells me that the fourth one is not going to be successful, for example. And what about the SART data and a couple of other data that shows that after 7 IVFs, the cumulative, optimistic cumulative live birth rate is close to 87%. I also sometimes tell my patients that in countries who can afford it, like Belgium, like Israel, where the government pays every IVF cycle, they cover up to 7 to 8 cycles. So that is the only option that I have, that to explain to them that maybe, since we have done everything else that could have been done, repeating it would be the best choice.
So I get the prerogative as the moderator to finish with my thoughts, but this was a very provocative panel. I enjoyed speaking with all of you. It was fantastic. So the reason I chose this topic is I think recurrent implantation failure is really one of the last frontiers of our group. It's frustrating for a clinician, it's very frustrating for a patient. My advice would be, please look at all aspects of the cycle before you talk about assigning a new diagnosis to a patient. It sometimes feels good to say you have recurrent implantation failure, makes them feel like you're going to do something differently, but really you have to go back and say, what has happened and what can I improve? Everything from metabolism to lifestyle, to the actual cycle itself, to the uterus, to endometriosis, et cetera. But I would be very, very careful with over-diagnosing and over-treating. We make this decision in medicine all of the time on when we will succumb to the patient's desire for an extra test or an extra therapy that we're not convinced will work, but let's try it anyway. But I try to restrict that to things that I think have no harm. There are therapies that are being proposed that have real harm. So I'd be very, very careful with anti-rejection drugs. I'm not convinced platelet infusion is yet safe. And then there's a cost. I think we have one question. Yes, please.
Actually, Dr. Nandita just mentioned that, you know, sometimes when we had failures, you would advise a surrogacy or a donor cycle. And we have seen that many times changing something helps this patient. So there are probably these immunological factors, like you said, over-diagnosing but sometimes you need to diagnose because there are certain HLA typings when we do. I'm sure, I think, you know, she's also looking into it, and you see a lot of matching in these couples, which is probably a cause. And we've had a couple of patients, you know, they come and they've been told that, you know, there's nothing more to be done. But a few of these tests have revealed that if they kind of continue using their own gametes, probably the chance of successful pregnancy is going to be very minimal. So sometimes we overdiagnose, but maybe sometimes we should, you know, probably not underdiagnose as well, because that's a problem. The second point I just wanted to make is many times people come with a thin endometrium or Asherman's, which is post dilatation and evacuation. And many times, you know, they've had 2 or 3 of such incidences, and now they're thinking of an endometrial factor. But the question is, why did they land up with the, you know, 3 miscarriages? So you just tend to look at the endometrial factor, not considering that even if you correct this, they could still land up with an abortion due to some other factors. So maybe all these things, if we kind of build into our evaluation, it might help. Thank you so much.
Thank you for that comment. I think we have one more.
Just wanted to make another point. I agree with her when she says about endometrium, because we test for endometritis and we do CD138 in all our failed cases. Even if the failure comes, if it's an IVF failed from somewhere outside, we are doing it. And I don't have the data, maybe I can present it later, but if it shows endometritis and you treat it, again take a biopsy and then do, the results are actually good. So I agree with her 100% that I believe endometrium is one part of the story which is not that well looked after, because all of us are talking about the embryo and how it should be tested and everything. But endometrium is something which is probably not looked as tuberculosis.
Thank you. So I think that we're going to end here. I think we're left with, one, we should be discussing this at the next journal club, and I thank you for the participants. And secondly, I don't have a full recommendation for you. You're just going to have to continue with your wonderful clinical acumen and treat your patients well.
Yes.
And I think the question that we heard very much at the end here was, what about male factor? I couldn't agree more. I wish we had talked about it, that the male factor probably, it must have a contribution, but we're going to have another discussion about where it goes.
Kurt,
We don't have any
No,
tests
Kurt,
which
we've
have really
seen
proven.
patients with really severe oligospermia. They take longer to get pregnant, even if the girl is normal. You know, she has a good AMH, good endometrium, good uterus, but they take longer to get pregnant. I mean, this is the counseling that I do, and I've noticed it in patients. So there is a male factor which causes this. So maybe the PGTA, we do non-invasive testing of the embryos. So that's also a very good technology for these patients.
We do a lot of metabolic testing for our men now, and we would be treating pre-diabetes and high insulins in men because we find we get much better embryos and much better implantation. But I think there's also an association with miscarriage as well. So I think somehow it's affecting the embryo to some extent, and certainly embryology. Yeah.
Kurt, I had a question. Sorry.
No, so basically, I mean, initially it was said that a high DFI probably could result in recurrent implantation failure, but I think there's not much evidence on it, and even what I found in my practice is that we didn't have a higher incidence of high DFI in patients who have recurrent. It could be a very small percentage of it. So, but there's no identifiable factor which, though probably, as Nandita said, oligoastenospermia could be one of the factor, but we really cannot identify a particular factor in the male which can result in implantation failure, because here again, the paternal age also really, it says that doesn't contribute to implantation failure as the female.
I think we are crossing the time, but quickly I've had a very small methodological question about your study, which is why was implantation taken as sustained implantation, which means presence of fetal cardiac activity on ultrasound, and why not serum beta HCG? Would that not differentiate with preclinical pregnancy loss then?
Well, we had a long discussion. We probably should have talked about this earlier, but we had a long discussion about this term itself. Should we be considering recurrent implantation failure to be the lack of a serum HCG? However, we extended it to a biochemical pregnancy for two reasons. One, it's an equally bad outcome for the clinician and the patient. And secondly, it draws the line to recurrent pregnancy loss, because biochemical pregnancy is not in the recurrent pregnancy loss issue. So we were trying to make a continuum to draw the line that once you see a clinical pregnancy, then you're looking more for reasons for recurrent pregnancy loss rather than recurrent implantation loss. So it was a conscious decision. The nomenclature is not perfect, but that was the rationale. So we went over mostly because this was a great discussion and we got the audience involved at the last minute, which I really enjoy. But because we're live, I'm going to say goodbye now. Again, this is a Fertility and Sterility Global Journal Club. I thank you all for watching and participating, and I thank you for my participants as well. And I hope we can do this again sometime in the future.
I think we would like to thank Kurt and Fertility Sterility. It is really wonderful. I think it was fantastic discussion, and thank you, Louis. Thank you, Madhuri. Thank you, Sujata. And it was really, and thank you, audience, for sitting through this so patiently. Really enjoyed it. And now I want all of you all to please be present for the first convocation. And those who are getting the fellowship, please go outside and gown yourself. Thank you. Thank you.
Thank you.